المحاضرة ما قبل الأخيرة، وبعون الله المحاضرة القادمة تكون المحاضرة الأخيرة. صوتي واضح بس سمعوني والسلايدات واضحة؟
عندي الصوت.
إذا اليوم إن شاء الله تكون المحاضرة حول two different bleeding disorder. One is concerned about the primary hemostatic disorder concerning with the platelet disorder, which is the ITP, and the second is a clinical pathological syndrome composed of both thrombosis and the bleeding at the same time, and the bleeding is attributed to both platelet disorder, platelet decrease in number, as well as coagulation factor consumption. This is the DIC, which is very important topic. I skipped the coagulation factor deficiency, like the hemophilia and the von Willebrand disease, because you may take it in another courses and another specialty, and to save time and in order to get just example of bleeding disorder. Today, objectives of this lecture, first of all, is to recognize the ITP, which is immune thrombocytopenic purpura types, the diagnosis and the treatment, which is very important topics. You may find it in clinical medicine practice, in clinical pediatric practice, as well as even in obstetric practice. So you have to concern about the immune thrombocytopenic purpura in the terms of pathophysiology and the treatment decision. Then we will take example about the drug-induced thrombocytopenia, and one of the important example, which is also present in the clinical practice, which is the heparin-induced thrombocytopenia. We will talk about the types and the treatment. And the second part of the lecture, we will demonstrate the pathogenesis and mechanism of DIC, and then we will identify the causes of DIC and their different clinical presentation. Last lecture, we had started the approach for the bleeding disorder, and we concerned that we have two types of bleeding disorder. One is attributed to primary hemostatic defect, and the second is attributed to the secondary hemostatic defect. The term primary hemostatic defect is usually confined to defect in either platelet number or platelet function, or defect related to the vessel wall disorder. Therefore, we have primary hemostatic disorder due to vessel wall disease, whether congenital مثل ما اتفقنا على انه hereditary hemorrhagic cholangiectasia, or acquired vessel disease like in vitamin C deficiency, scurvy, or in steroid-induced purpura because of the atrophy of the wall of the vessels, collagen fibers of the vessels, as well as the senile purpura, in addition to the vasculitis as a one form of vascular purpura like in phenylketonuria purpura and SLE, in addition to the infection that induce vascular purpura like in meningococcidia. The typical features of vascular purpura is the presence of palpable purpura, palpable petechiae. So by clinical examination, if we find the pinpoint bleeding spots over the skin which are palpable, these will be suggested that this is a vasculitic in origin. While the petechiae that is flat, which is not palpable, is usually related to platelet disorder, either platelet deficiency, thrombocytopenia. And we talked that thrombocytopenia will induce spontaneous bleeding spots if the platelet count less than 20,000, but it may induce provoked bleeding if the platelet count between 50 to 100,000. Otherwise, the patient may be without bleeding unless exposed to trauma. If the platelet count between 50,000 to 20,000, some of them may be presented with mucous membrane bleeding, like epistaxis, skin bleeding, in addition to the gamma bleeding. The different causes of thrombocytopenia, we had talked that the causes may be due to decreased production or hemodilution or increased sequestration or pooling. Pooling like in hyperspllenism, sequestration and pooling like in hyperspllenism. Peripheral destruction, like what will be discussed today, immune thrombocytopenic purpura, or peripheral destruction due to DIC, or it may be due to bone marrow destruction or bone marrow poor production, like in cases of aplastic anemia, like in cases of myelodysplastic syndrome, or in cases of acute leukemia. And we have rare causes for thrombocytopenia, which is hemodilution in case of massive transfusion. Whenever the patient receives a very high number of blood units, this may induce dilution of the platelet count and may induce dilution of thrombocytopenia. The second form of hemostatic disorder is the secondary hemostatic disorder, and this term is usually described any defect due to coagulation factor deficiency. And this coagulation factor deficiency may be acquired or congenital. Congenital coagulation factor deficiency, like hemophilia A, hemophilia B, they acquire due to vitamin K antagonism. We all know that we have the four coagulation factors, which are 10, 9, 7, 2, are vitamin K dependent coagulation factor. So in any condition where there is a vitamin K deficiency, this will result in reduction in the production of this four factors, which are vitamin K dependent factors. Example, patient who had vitamin K antagonist, مثلا هذا اللي يستخدم الوارفرين anticoagulation هو شغله يسوي blocking for vitamin K production of these coagulation factors. Or we may have decrease in vitamin K absorption, for example, patient with malabsorption syndrome, celiac disease. We may have other causes that result in reduction in the production of vitamin K inside the intestine by bacterial intestinal sterilization and eradication of the normal bacterial flora of the intestine that is responsible for vitamin K production. Like again, those patients who are using for long duration the broad spectrum antibiotic, this will result in a reduction in these bacterial normal flora. وبس هذا. Those people in the eye intensive care unit, they may kept on total parenteral nutrition, and this will also affect the normal flora in the intestine. Clinical approach for bleeding disorder should rely on history of bleeding, if the bleeding is spontaneous or provoked. This will rely on the severity. The distribution of bleeding, is the bleeding in the skin, mucous membrane, or in the deep tissue? This will very useful to differentiate primary from secondary hemostatic defect. We have to rely on the objective assessment of severity of bleeding through the intervention, the need for transfusion, the need for admission to the hospital, the need for blood product replacement. And it is very important whenever approach the patient with a bleeding tendency, we have to review the past medical history as well as we have to review the drug history, because these are very essential elements that may result in bleeding. Today, we will go through the immune thrombocytopenic purpura as one example of a primary hemostatic disorder and induced by decrease in the induced by increase in the platelet peripheral destruction despite normal production in the bone marrow. It is also called primary immune thrombocytopenia. ITP هي جاية من I for immune, TP for thrombocytopenia. سابقا كانوا يقولون I from idiopathic, but since there are some causes of immune thrombocytopenia with a non-underlying cause, therefore they replace the term idiopathic thrombocytopenia into immune thrombocytopenia, and they classify the immune thrombocytopenia to primary immune thrombocytopenia, which may be idiopathic, or secondary immune thrombocytopenia, which may be induced by different underlying causes. So, primary immune thrombocytopenia, it is an autoimmune bleeding disorder. If it is idiopathic, there will be no recognizable underlying cause. But the mechanism is well understood that primary immune thrombocytopenia is due to increased destruction of platelet by immune mechanism. In a situation where the platelet opsonized by antiplatelet antibody and then removed prematurely by the reticuloendothelial system, look to this figure. Normally, the platelet should have no antibody overlying its surface. Due to any trigger for immune system, whether non-trigger or unknown trigger, there will be a specific generation of antiplatelet antibody. These antiplatelet antibody, which may be IgG or IgM, antiplatelet antibody, will get opsonization over the surface of the platelet. So it will coat the platelet surface. And here it will give a structure which is composed from platelet coated with an antibody. This structure is already considered and recognized by the reticuloendothelial system, which is the spleen, one of these organs of the reticuloendothelial system. It is recognized as abnormal foreign cells or foreign structures that need to be engulfed and removed by the activated macrophage system. And the outcome is that most of these platelets, which are covered by these antibody, will get distracted inside the spleen, and it will removed from the spleen, result in decrease in the number of the circulating platelet in the circulation. Primary immune thrombocytopenia is classified into two types according to the onset. We may have acute onset immune thrombocytopenia or chronic onset immune thrombocytopenia. We may classify ITP according to the age incidence into two types, pediatric ITP and adult ITP. But this classification is rather old classification, that pediatric and adult ITP. It has been substituted by the onset classification, acute and chronic ITP. Chronic ITP is indication that the disease process is extending beyond 12 months. So any persistent disease beyond 1 year is labeled as a chronic ITP. While the acute ITP is distinguished into two phases, either a newly diagnosed acute ITP between which is less than 3 months duration, where the disease may remit spontaneously and may be eradicated spontaneously, and which is self-limiting, or it may be persistent acute ITP, where the duration is extending from 3 months up to 12 months. However, still there is a possibility of spontaneous remission and spontaneous response, and the patient get full recovery from the disease. But those who had chronic ITP that persist for more than 12 months, they are unusually to get remission from the disease, and the disease will run in a chronic course and lifelong course. Epidemiologically, it was being demonstrated that most of the acute ITP are pediatric ITP. So any case of immune thrombocytopenia in pediatric age groups may fit into acute onset ITP that associated with very high rate of spontaneous remission, self-limiting without any chronicity, while the chronic ITP is commonly related to the adult ITP. So many of the adult cases of immune thrombocytopenia will run in a chronic course. هنشوف شنو الفرق بيناتهم. Primary immune thrombocytopenia اللي هي قلنا هي most likely occur acute ITP and acute pediatric ITP. It is self-limiting disease. It is commonly affects the children between 2 years up to 6 years. The equal incidence between the boys and girls. It is characterized by sudden onset. Usually, there is an immune trigger mechanism before the presentation of acute pediatric ITP. The immune trigger mechanism, which is usually preceding the sudden onset of ITP by 1 to 3 weeks, which is either viral infection or immunization. And this is commonly seen in 2/3 of the cases. The mechanism is similar to any ITP, is the antibody against the platelet surface, but here the antibody is IgM antibody. It is directed against the platelet surface. But this antibody is generated basically against the immune trigger, which is either the viral infection or immunization. And this IgM antibody that is generated against the viral antigen is cross-reacting with the platelet glycoprotein. So basically, the antibody is not generated against the platelet. It is generated against either viral antigen or any vaccine or any immune trigger. And habitually, through the cross-reaction, this IgM antibody will direct against the platelet glycoprotein, causing opsonization of the platelet and subsequently causing the engulfment of the platelet by the reticular endothelial system. فدائما بيدياتريك اي تي بي الام تجيب طفلها على غفله، تجي الصبح تجي العصر كل شيء ما بي ابني يلعب يقمز، ما بي شيء، لا مسخن، لا عنده حراره، لا عنده شيء، ياكل زين ويلعب، لكن انا اغسل له شفت عنده طقع بجسمه، هاي طقع بجسمه اليوم طلعت، البارحه انا غسلت له كل شيء ما بي شنو، وبعدين وراها مثلا شو زادت هاي طقع بخشمه، بعدين بحلقه شفت مثل هاي الطقع. اذا هاي كلها علامات انه sudden onset purpura. Sudden onset purpura induced by thrombocytopenia, and usually معقول sudden onset spontaneous معناها severe thrombocytopenia. بعدين بنسأل بالهيستوري يقول لك والله هو يمكن هو نعم قبل اسبوعين كانت عنده بلاعيمه توجعه شويه، صار عنده سخونه، خطيته علاج بسيط، خطيته خافض الحراره صار زين، او مثلا الكورس مال اللقاحات مالته قبل اسبوعين كانت عنده. فهذا دائما the preceding history of immune trigger will be suggestive that the disease is acute onset and it is self-limiting and it is spontaneously and may undergo spontaneous remission, and this is due to a cross-reacting antibody rather than platelet-specific antibody. Usually acute pediatric ITP associated with profound thrombocytopenia مثل ما قلنا، لذلك يسوي لي spontaneous skin bleeding, mucous membrane bleeding، ممكن يكون عنده fatigue، ممكن يكون عنده small ecchymosis over the skin, as well as there is a mucous membrane bleeding over the gums, and it may be associated with epistaxis as well. In adolescents, there may be menorrhagia also. The disease usually resolves within 4 to 6 weeks, so it is a self-limiting disease associated with spontaneous remission after these antibody will get degraded. It is associated with spontaneous recovery in 90% of the cases. فإذا دائما يحتاج reassurance للأم، reassurance للعائلة، لأنه it is a self-limiting disease. We have to wait up to 4 to 6 weeks. We have to keep observation. ننصح المريض بهاي الفترة، نقولها للأم هاي لا يتقمص هواية، لا يروح يلعب، لا يطخ راسه بفد شيء، لأنه عنده severe thrombocytopenia، ممكن يصير عنده severe bleeding، يكون له threatening bleeding. فعلينا بس نحدد حركته ونحافظ عليه ونراقبه، ما يحتاج أي intervention لأنه هو حيكون ب spontaneous remission and it will recover. طبعا إذا كان أكو certain complication نتدخل، ناخذ علاجات. عادة المريض بالacute ITP pediatric ITP يكون well active, no fever, no lymphadenopathy, no splenomegaly, and the patient looks normal. بس بالتأكيد لازم نسوي له investigation مثل ما احنا نشرح بعد شوية، اللي هي أهم شيء CBC and blood film to exclude other differential diagnosis اللي دائما نخاف من عندها، اللي ممكن تكون other causes for decrease of production rather than causes of increased destruction. Most children need no treatment in a pediatric acute ITP. 10% may get chronic course. وذول شنو؟ يعني فقط 10% ممكن يصيرون عندهم chronic ITP، واللي هو عادة بعدين حنشوفه بأنه then it is proof that it is not idiopathic. It is due to other connective tissue disease. مثلا those patients who had a chronic ITP in childhood, at adulthood they are liable to get SLE as one of the complication أو بالعكس ITP is one of the manifestation of SLP. Recurrence is unusual. Chronic adult ITP مثل ما اتفقنا عليها chronic usually goes with the persistent thrombocytopenia more than 12 months, usually occur in adult patient. It is a common disease. It's associated with the persistent thrombocytopenia. It is most commonly affect the young adults, 70% of the cases below the age of 40 years. The women affected 3 times more than the men. The disease characterized by insidious onset. وتجي المريضة أنا صار لي 6 شهور أشوف وقع عندي جسمي مرات يكون خشمي دم مرات من أنظف أسناني يصير عندي رغبة بالأسنان يصير عندي نزف بس يروح بس هسه شو ده يزداد لأنه هو insidious onset. عادة in chronic ITP there is no immune trigger evidence ما أكفت هذا ال preceding viral infection or vaccination. No history of preceding infection. Presentation gradual, recurrent epistaxis, gingival bleeding or menorrhagia in women. Multiple recurrences are common and the spontaneous long-term remission are rare. In both acute and chronic ITP, the physical examination must be unremarkable apart from the bleeding spots أو perforal. يعني شنو؟ The presence of lymphadenopathy and splenomegaly suggest a different underlying diagnosis. خلوهم بالكم. ما أفكر المريض ITP إذا لقيت عنده splenomegaly. ما أفكر المريض ITP إذا لقيت عنده lymphadenopathy. لازم أروح أدور على الأسباب الأخرى. ITP classically there is no organomegaly nor lymphadenopathy. The mechanism, this is due to autoimmune disorder with a specific IgG antibody directed against platelet glycoprotein 2b3A. It makes opsonization of the platelet and then the platelet will be removed by the spleen. So the shelf life of the platelet will be reduced from a few days to a few hours only in that case circulating the platelet could no number. عمود نلخص اللي حكيناه. The pediatric ITP, the peak age incidence 2 to 6 years, adult ITP between 20 to 40 years. The female to male ratio in pediatric group 1 to 1, in adult 3 to 1. Preceding trigger, pediatric ITP present, either infection or vaccination, in adult ITP not present. The onset of symptoms, it is sudden onset in pediatric, while in adult sudden or gradual. Severity of thrombocytopenia. Pediatric ITP, it is less than 20,000. Severe thrombocytopenia. Adult ITP, usually moderate thrombocytopenia, less than 50,000. The duration of the disease in pediatric ITP, recovery will be expected within 4 to 6 weeks. And in adult ITP, usually it is associated with the long duration. Outcome. Pediatric ITP, self-limiting, spontaneous remission, no recurrence, and no need for treatment. Adult ITP, it's a chronic, associated with the recurrence, and less likely to get spontaneous remission, and needs treatment in almost all cases. Diagnosis. For diagnosis of ITP, we have first of all rely on the history and the physical examination. Then we have to proceed for investigation. The first investigation is CBC to prove that there is a thrombocytopenia and the level of thrombocytopenia. I have to look for a blood smear because in ITP there must be a normal morphology of a blood cell. يعني شنو؟ إذا ITP وشوف عنده left shift هذا unlikely to be ITP. هذا معناها there is a bone marrow disease. إذا إذا thrombocytopenia وياها عند leukotroblastic picture, this is definitely against ITP. معناها there is a bone marrow destruction. إذا لازم أدور بالperipheral blood and the blood smear for abnormal cells. وجود abnormal cells معناها there may be an underlying cause on the bone marrow and the diagnosis is not ITP. The other features of the ITP, it is a prolonged bleeding time. هنا bleeding time يعتمد على vessel wall يعتمد على platelet لذلك أكيد يصير prolongation أكثر من 7 دقائق. لكن أكيد لازم أفرقه من الأذر coagulation factor deficiency فلازم أدز المريض PT and PTT which must be normal. يبقى البون marrow examination. In ITP قلنا عليها it is a disease of increased destruction, peripheral destruction of the platelet with normal production in the bone marrow. So in ITP, the bone marrow examination usually normal with plentiful megakaryocyte. السؤال نحتاج لتشخيص المريض الاي تي بي نسوي له بون مارو؟ الجواب لا مو كلهم. هسه هنشوف شنو الحالات اللي مثلا يسمى بون مارو، لانه الاي تي بي يكون كلينيكال index of suspicion زائد normal blood film, negative physical examination, thrombocytopenia may be sufficient to consider that the patient ITP. ممكن اسوي له observation او ابدي له therapeutic trial وبعدين اشوف الريسبونس على ضوءها. البون مارو مو دائما نحتاجه، لكن اذا سوينا بون مارو examination حيكون هو plentiful leukocyte with normal cellularity. So bone marrow examination is not mandatory initial investigation. It should be considered in these conditions. If there are any abnormality on the blood smears مثل ما اتفقنا، thrombocytopenia زائد اكو abnormal مثلا بلاست سيل، thrombocytopenia واكو عندي leukocytic picture، فلازم اسوي بون مارو لان هذا مو اي تي بي. In any older patient over 60 years لازم افرقه من الام دي اس، لان الام دي اس ممكن يجيني اشياء thrombocytopenia، كلاسيك انيميا ممكن يجيني اشياء thrombocytopenia، فلذلك لازم اسوي بون مارو ستدي اذا المريض beyond the expected age group. او انه انا المريض توقعته اي تي بي وعطيته علاج ورا اسبوعين من العلاج failure of response، معناها the diagnosis is questionable. So failure of response within the first 2 weeks up to 1 month of treatment. اخير شيء اذا المريض هو دا افكر هذا chronic persistent اي تي بي واحتاج اسوي له splenectomy. Any patient needs splenectomy لازم اتاكد بانه the bone marrow production is normal before proceeding for splenectomy. So these are the 4 indications of bone marrow study in patient with suspicion of ITP. Before starting the treatment management of ITP, I have to exclude secondary ITP. Secondary ITP, it is an indication that this thrombocytopenia is one of the manifestations of systemic disease. مثلا ITP may be a presentation of systemic lupus erythematosus. لذلك المريض لازم يدرس serology anti-nuclear antibody وanti-double stranded DNA. ممكن ITP is a presentation of viral infection مثلا viral hepatitis، لذلك المريض لازم يدرس hepatitis screen او HIV infection لازم يدرس المريض HIV serology. بعض الحالات من ITP associated with H pylori infection، لذلك it is an indication to screen for H pylori. ممكن يحتاجون even eradication therapy for the H pylori infection. That is the trigger for new thrombocytopenia. ممكن ITP is a presentation of chronic lymphocytic leukemia، لذلك قلنا اذا المريض عنده lymphadenopathy او splenomegaly لازم افكر that the thrombocytopenia is due to systemic disorder. أو ممكن يكون ITP is a presentation of lymphoma. Differential diagnosis is very important to differentiate that this thrombocytopenia not due to acute leukemia, not due to aplastic anemia, not drug induced, and in a pregnant lady who presented with thrombocytopenia, it is not gestational thrombocytopenia اللي عادة تصير بالثيرد trimester وتكون self-limiting وتكون mild thrombocytopenia. And this thrombocytopenia not due to non-immune thrombocytopenia اللي هو part of microangiopathic hemolytic anemia اللي هو thrombotic thrombocytopenic quadra. Treatment. شخص المريض ITP. The goal of treatment is to prevent bleeding and to avoid bleeding in the patient with the thrombocytopenia rather than to correct the platelet count. يعني مو الفكرة انه المريض عنده thrombocytopenia نسبتها 50 لازم اوصلها 150 عشان اقول له صرت زين، لا مو الفكرة. I have to treat the symptoms and the presentation rather than the platelet count. ممكن المريض يبقى without any bleeding لكن البليتلت كاونت تبقى 50,000 60,000 70,000. That's fine. لأنه there is no much benefit from extensive treatment with mild increment in the platelet count despite the patient is not having any bleeding. Then the goal of treatment should be based on the signs of the bleeding and not only the platelet count. The first choice of treatment is the corticosteroid, prednisolone 1 mg per kg per day for at least 2 weeks and check the response. And if the response by increasing platelet count, I may do slow tapering of the steroid over 1 month duration. In life-threatening bleeding, I may substitute oral prednisolone by high-dose parenteral corticosteroid like methylprednisolone 1 gram per day for 3 days. This can give a response in 65 to 85% of the cases. أحتاجه very profound thrombocytopenia, it may get a rapid response within the first week of the treatment. Second choice treatment, if the patient failed to respond to steroid, I have to think with the splenectomy. احنا قلنا قبل شوية the site of the removal of the platelet was spleen. لذلك in splenectomy 75% of the patient may get complete response. بس مع هذا 15% may get relapse after splenectomy. The third line of treatment is the monoclonal antibody, rituximab, anti-CD20. It can give a response in 50%. We may give combination rituximab plus steroid to induce a longer duration. Monoclonal antibody is indicated in refractory patients or those relapse after splenectomy or those patients who are relapse after steroid therapy. أقدر أعطيهم monoclonal antibody rituximab. Other lines of treatment is the immunosuppressive treatment اللي هو الازاثايبرين أو cyclosporin. دول وين نستخدمهم؟ المريض اعطيته ستيرويد صار عنده ريسبونس، كل ما ابدا اسوي له تيبرنج بالستيرويد يرجع الديزيز يصير عنده ريلابس، فهذا يحتاج له ستيرويد سبيرنج ايجنت. بستخدم immunosuppressive تريتمنت از ستيرويد سبيرنج ايجنت، اسوي اوفرلاب بين الازاثايبرين والستيرويد وشوي شوي اسحب الستيرويد من العلاج وبقي الازاثايبرين على مود المريض يصير عنده rebound flare up of the disease. Over the last 10 years there is a new modality of treatment اللي هي هاي نيو موداليتي ممكن تجي السكند لاين اوف تريتمنت، هي ثرومبوبويتين ريسبتور اجونست. واحده منهم راموبلوستين والثاني الاترموبايل. Those are thrombopoietin receptor agonists indicated as a long-term treatment for chronic disease. مريض ما استفاد من الستيرويد، ما استفاد من السبلينكتومي، ما استفاد من immunosuppressive treatment، اخليه على thrombopoietin receptor agonist. او المريض ريلابس افتر سبلينكتومي او المريض ريفيوزنج سبلينكتومي. ان لا ثريتنينج بليدنج، مريض عنده سيرجري، مريضه عندها ليبر، مريض يعني يصير عنده visceral bleeding, intracranial bleeding. Is there any modality to get a very rapid response? نعم. Very rapid response can be achieved within few days by using intravenous immunoglobulin or anti-D antibody. For Rh positive patient before splenectomy, they can get a rapid response in 70 to 80% of the cases. These are indicated for emergency bleeding, in emergency surgery, or in pregnant lady near term and or under labor. Other lines of treatment is the antifibrinotic therapy, tranexamic acid. هذا كلش يفيدنا من mucous membrane bleeding. Tranexamic acid to arrest the bleeding. So what about platelet transfusion? احنا ما انه عنده circulating platelet antibody، ما حتصور platelet transfusion حتكون ذات فائدة. So it may not increase the platelet count, but it can be transfused to avoid the life-threatening bleeding. It is better not to be used because these transfused platelets destroy the quickly. لكن إذا ما عندي حل آخر والمريض under surgery وهذا intravenous immunoglobulin اللي هو أسرع واحد ياخذ له 48 ساعة يلا يصير ريسبونس، فخلال هاي الفترة لازم أعوض المريض البليتليت على مود أتابع الريسبونس. Now I will skip to the heparin-induced thrombocytopenia. This is a thrombocytopenia that occurs in about 10% of the patients receiving heparin. It is more with the unfractionated heparin and much less common with low molecular weight heparin. It's important to diagnose this entity to prevent a fatal complication. Then heparin-induced thrombocytopenia may complicate by thrombosis and may cause life-threatening thrombosis. We have two clinical syndromes of heparin-induced thrombocytopenia, depend on the type. Type 1 heparin-induced thrombocytopenia develops immediately after using heparin therapy less than 5 days. This is a self-limiting type, non-immunogenic, associated with insignificant mild thrombocytopenia and resolved after discontinuation. هذا ما في أي مشكلة خلال 5 أيام الأولى لأنه non-immunogenic ما يصير وياه thrombosis. لكن المشكلة type 2 HIT develops 5 days after starting heparin therapy, associated with the severe thrombocytopenia and associated with life-threatening thrombosis in both veins and arteries and known as a white clot syndrome. في هيك حالة what is the alternative؟ مريض عنده thrombosis وما heparin is not a license because of this HIT. I have to shift the patient to direct thrombin inhibitors or argatroban as substitution therapy. في بعض الحالات يصير عندي ديليما اللي هو مريض عنده ثرومبوسيس وعنده ثرومبوسايتوبينيا، هاي شويه ما نتصورها، هم ثرومبوسايتوبينيا ويا ثرومبوسيس. This syndrome should always direct your attention to these differential diagnoses. أول واحد heparin-induced thrombocytopenia where the thrombosis affects large veins and the arteries, أو thrombotic microangiopathic hemolytic anemia like TTP or HUS. Thrombosis affect the small arteries and the arterioles and affect the CNS and the renal system. أو disseminated intravascular coagulation. أو هسه بالجديد اللي اكتشفوها after corona vaccination اللي هو vaccine induced thrombotic thrombocytopenia. خليت علامات أمام كل واحدة. In all of these conditions, platelet transfusion is contraindicated. In HIT, TTP, and in VIT, the platelet transfusion is contraindicated because it will induce more thrombosis. Except in disseminated intravascular coagulopathy, the platelet transfusion may allow if the patient presents with severe bleeding. DIC. DIC is a consumptive coagulopathy. It's acquired clinical pathological syndrome. من اسمه disseminated intravascular coagulation, so it is a combination of thrombosis plus hemorrhage. And the hemorrhage due to both thrombocytopenia, that's the primary bleeding, and coagulation factor consumption, يسوي secondary hemostatic bleeding. خليت لي ثرومبوسيس قبل الهيموريج لانه حسب السيكولي هنتكلم بعد شويه، هو يبدي بثرومبوسيس بعدين يصير consumption of the platelet, consumption of the coagulation factor, فيصير عندي bleeding. So DIC is not a primary disease, it is a clinical pathological syndrome secondary to several diseases مثل ما حنشوفها بعد شويه. The pathogenesis started with widespread inappropriate intravascular deposition of fibrin. This fibrin clot will induce consumption of the coagulation factor and the platelet. The trigger for fibrin deposition inside the vascular system is either release of the procoagulant materials, the tissue factors, or widespread endothelial damage that induce platelet aggregation. شنو الأسباب اللي تسوي لي release of the procoagulant tissue factor to the circulation بحيث تسوي لي fibrin deposition? This may be induced by trauma. مريض عنده fractures، مريض عنده road traffic accident، هاي التروما تسوي لي DIC عن طريق excessive release of tissue factor. Obstetric complication مثلا amniotic fluid embolism أو preeclampsia toxemia or premature separation of the placenta. كلها are rich with tissue factors. Whenever this tissue factor releases in circulation, it will induce fibrin deposition within the circulation. Malignancy. The commonest malignancy اللي احنا عرفناها اللي يسوي لي DIC هو acute promyelocytic leukemia لأنه the granules in the promyelocyte are rich with tissue factor. بعد adenocarcinoma مثلا prostatic adenocarcinoma. Organ failure, liver disease, pancreatitis. Infection, severe falciparum malaria infection. Incompatible blood transfusion, hemolytic transfusion reaction, and toxic reaction due to snake bite or scorpion bite. كل هاي تسوي لي release of tissue factors، والtissue factor تسوي لي thrombosis وبالتالي يسوي consumption of the coagulation factor ويسوي لي DIC. Other category of DIC is induced by endothelial damage، ما له علاقة بالtissue factor، العملية كلها عبارة عن endothelial damage. والendothelial damage هذا اللي حيسوي لي release of the endothelin والendothelin and other endothelial matrix component will induce the coagulation cascade activation. Endothelial damage مثلا in case of endotoxemia following gram-negative septicemia or meningococcemia, septic abortion, viral infection مثل viral hemorrhagic fever, vascular malformation مثلا a very large aneurysm, abdominal aortic aneurysm مثلا, severe burn on hypothermia. These are the causes of endothelial damage that may trigger for DIC. شنو الميكانيزم in more details؟ ايش قلنا؟ قلنا هي DIC هي عملية تبدي بالstimulation of thrombosis. The trigger that stimulates thrombosis هو أما release of tissue, there is tissue injury and release of tissue factors كما عددناها قبل شوية من malignancy إلى التوكسين إلى التروما or endothelial damage and exposure to the subendothelial tissue, release of endothelium and stimulation of the platelet adhesion. هذا اللي هو يصير بالسبتسيميا او مثل ما قبل شوي ذكرناها بالهايبوثيرميا and other example like obstetric complication مثلا septic abortion or missed abortion. So both these factors will activate the coagulation cascade and formation of thrombi, and these thrombi will be situated inside the circulation. فإذا حيصير عندي microvascular thrombi within the center of the circulation. This microvascular thrombi will induce excessive consumption of the coagulation factor, excessive consumption of the platelet, so it will result in factor deficiency and thrombocytopenia and subsequently result in a bleeding tendency. بنفس الوقت, this intravascular thrombus, it will induce ischemia to the surrounding tissue. So the thrombotic complication of this intravascular thrombus will result in organ failure and ischemia of the vessel of the tissues supplied by these vessels. وبس هاي, it will induce the trapping of the RBC and the fragmentation of the RBC while the RBC passes through these thrombi, and this will result in microangiopathic hemolytic process and the schistocyte release to the circulation. فإذا هي عملية thrombus inside the vessels. هذا thrombus will induce more activation of the more consumption of the coagulation factor, more consumption of the platelet, and it will result in bleeding. بنفس الوقت, it will induce thrombosis and subsequently ischemia to the tissue, and at the same time it will induce fragmentation of the RBC and causing microangiopathic hemolytic process. للي ما افتهمها نعيدها بهذا المخطط. DIC يبدي بسيستميك activation of the coagulation, يسوي لي intravascular deposition of fibrin, and this will induce thrombosis of the small vessels and subsequently organ failure. بعدين يسوي لي depletion of the platelet and the coagulation factor, يسوي لي bleeding tendency. لذلك عملية ال DIC هي combination of pulmonary hemorrhagic or thrombotic syndrome with organ dysfunction. The clinical manifestation is bleeding more than the thrombosis. لكن هي العملية تبدي بالتhrombosis أولا. 5 to 10% of the cases may present with thrombosis and the gangrene of the leg. So we have two forms of DIC: acute DIC that present with the bleeding, and the chronic DIC that present with thrombosis. Acute DIC present as a bleeding tendency, mucosal bleeding, GIT bleeding, bleeding from the sutures, bleeding from the incisions, bleeding from venipuncture, excessive petechiae and ecchymosis. It's associated with multiple organ failure and hypovolemia due to fibrin deposition within these organs and ischemia of these organs. The causes for acute DIC: DIC induced by bacterial septicemia مثل ما قلنا عليها بالمنجوفوكسيميا أو gram negative septicemia. The DIC following viral hemorrhagic fever, the DIC following acute hepatic failure or liver transplantation, and the DIC following road traffic accident and massive trauma, or DIC following obstetric complication like abrupt shear placenta. The second form of the DIC هو chronic DIC, where the thrombosis is the common presentation مثل ما نشوف هنا ischemic limbs induced by thrombus formation. هذا عادة chronic DIC. It is induced by thrombosis, which may be arterial or venous thrombosis. احنا clinically هذا extensive thrombosis اللي يصير وياه ecchymosis زائد gangrenous limbs نسميه purpura pulmonans, associated with acral ischemia مثل ما نشوف بالصورة with skin infarction. This is induced by active hepatic clotting system synthesis. يعني عملية الثرومبوسيس is slow process and there is enough time for the liver to generate a new coagulation factor. Therefore, thrombosis is much more than bleeding presentation. The etiology of chronic DIC, this is specific for DIC following missed abortion, following intrauterine fetal death, or the DIC following adenocarcinoma, or DIC following aortic aneurysm. All of these conditions are a slow process of DIC that give at times for the liver to synthesize more coagulation factor, and therefore the thrombosis will be expected more than the bleeding. If the DIC process affects the endocrine system, we have two syndromes لازم تعرفوهن وتحفظوهن. اللي واحدة من عندها اسمها Waterhouse Friderichsen syndrome والثانية اسمها Sheehan syndrome. These syndromes have a unique presentation in a patient who had in a setting of DIC. Waterhouse Friderichsen syndrome, it develops in meningococcemia. It is due to massive adrenal hemorrhage due to fibrin thrombi within the adrenal cortex. And then the acute adrenal insufficiency because of this massive bleeding within the adrenal glands. يجي acute Addisonian crisis إذا درستوها بالإندوكرين. Sheehan syndrome is the second endocrine complication of DIC. This is usually developed following postpartum pituitary necrosis. For example, a lady presents with normal labor or complicated labor associated with severe bleeding, and this bleeding associated with the tissue injury, tissue factor release, and endothelial damage, followed by hypovolemia. Secondary to this hypovolemia, there will be postpartum pituitary necrosis. And this postpartum pituitary necrosis, it will result in acute pan-hypopituitarism. So the patient will present with pituitary gland failure. Now has under hypothyroidism, has under adrenal insufficiency, but all of these are primary type, secondary type of apnea, rather than primary. It is due to pituitary failure to release the stimulating hormone for these gonads and these glands. Investigation for DIC. DIC قلنا عليه clinical pathological syndrome. It is not a disease by itself. It is a manifestation. It is a complication. لذلك no single test. It needs a clinical constellation of symptoms, clinical index of suspicion, plus these investigation. وهي thrombocytopenia, platelet count أقل من 50,000, which is almost always present in patients with DIC. Low plasma fibrinogen, hypofibrinogenemia, increase in the FDP, which is the D-dimer, which is specific for DIC, prolonged thrombin time, prolonged PT, and prolonged APTT, but this present only in 50% of the cases due to consumption of the coagulation factor. And by blood film, there is a fragmented RBC, usually less than 10%. I'm نفرقها من البرايمري microangiopathic hemolytic anemia. هسه ذن يشوفوهن انه ليش قلنا نو سنجل تيست؟ لانه ماكو واحد من عندهم يطلع 100% بالدي اي سي. لذلك هسه من تروحون اللي يريد يقرا عن دي اي سي وموضوع مهم يستحق القراءه، ما تكفي هاي السلايدات. لانه حنشوف الدي اي سي دايجنوستس بسكورينج سيستم. اكو سكور سيستم، هذا السكور سيستم اجمع به التريجر اللي حكينا عليه كلينيكال سيتويشن زائد اني اوف ذيس انفستيجيشن. من اجمع السكور سيستم اقول هذا المريض عنده دي اي سي. لانه there is no definite single test to investigate to define the diagnosis of the IC. Treatment. The disease is a serious, fatal. It depends, the prognosis depends on the underlying clinical condition. يعني مثلا ممكن إذا كان المريض underlying the infection, eradication of the infection can control the disease. Intrauterine fecal death, removal of the or evacuation of the uterus from the dead fetus may correct the condition. But we may have certain condition which may be a fatal condition. Therefore, the prognosis depends on the underlying condition. It needs an immediate diagnosis and immediate management, removal of the cause, the treatment based on the clinical presentation. And the diagnosis should be very energetic, that whenever you suspect the patient DIC, depending on the clinical picture, take your action to overcome this complication, because time factor is very important in managing DIC patient. شنو التريتمنت؟ التريتمنت تعتمد على الكلينيكال برزنتيشن اكثر ما تعتمد على الانفستيجيشن. يعني مو اجي اباوع ان هذا المريض عنده والله سيفير ثرومبوسايتوبينيا اعطيه بليتليت، وهذا المريض عنده برولونج بي تي اعطيه كوagulation فاكتور. لا، تعتمد على clinical presentation. مريض هو جايني with acute DIC, bleeding tendency, skin bleeding, epistaxis, menorrhagia, GIT bleeding. I have to suppress the bleeding by platelet transfusion, fresh frozen plasma transfusion, cryoprecipitate transfusion, or a prothrombin concentrate complex اللي هو يحتوي على فاكتور 10 فاكتور 10 فاكتور 9 فاكتور 7 فاكتور 2 اللي هنا الفيتامين كي ديبندنت كوجوليشن فاكتور. اذا المريض جاني with thrombosis, acral ischemia and purpura-fulminans, اكيد I have to start with anticoagulation therapy, and here the unfractionated heparin must be given as an infusion 10 units per kg per hour. يبقى ملاحظة جدا مهمة جدا مهمة انه is it safe to give antifibrinolytic therapy in patients with DIC? The answer is not safe. And antifibrinolytic therapy, tranexamic acid, is not recommended. اترك الجواب لكم حسب فهمكم للباثوفيزيولوجي. ليش ما اعطي tranexamic acid؟ ليش بالاي تي بي قلنا انه it is one option of the treatment؟ ليش بالدي اي سي it is not recommended to give tranexamic acid as antifibrinolytic therapy؟ لهنا انتهت المحاضرة.